Good morning, students. Today's topic is pulse. It is a cardiovascular system is among all vital signs. This is very important. This a very important cardiac vital sign is pulse. Pulse. What is pulse? Pulse is actually an alternate required and expansion of arteries as the wave of blood forced to the artery from the heart, and blood passing through the artery, and this coming to the artery through the left ventricle's contraction. When left ventricle contracts, this force is propagated to the wall of the artery, and this propagation of the force we are feeling on peripheral arteries. That is called pulse. And this pulse, what are the common places of pulse and how this is going to propagate? When it is propagating, it is taking some time. It is not actually as similar to the column of the blood is travelling. Before that, this force is coming and giving a pressure to the wall, and expansion of the wall happens. After that, this blood is coming up. So it is fraction of a second, milliseconds fraction. You will find there you will get this among all these peripheral this pulse. Suppose we can feel the pulse at cardiac, at the carotid arteries, at carotid arteries, at radial arteries, at femoral arteries, some brachial arteries. Lot of other places are there. You will get some fraction of a seconds difference. Suppose carotid artery pulsation, when we are feeling, that is 30 milliseconds after the systole, after the left ventricular contraction, we are 30 milliseconds after we are getting this pulsation. Like radial pulsation, we are getting 60 milliseconds, and femoral pulsation, you are getting 75 milliseconds, and brachial pulsation, you are getting 60 milliseconds. What is this pulse? Will tell you why this study is that much important, what information you will get from it. That is, what information you are getting, a frequency of these pulsations, and this frequency will tell you about the regularity or irregularity. Some arteries patency, we can judge whether artery is patent enough to carry the blood, and characteristics of arterial pressures and pulse waves we can feel from this pulse when we are measuring pulse. So, and a pulse when we are taking, it is a peak we can feel on our pulsatile, on our finger, with the fingers we can feel. That will give you the information about the resistance, that velocity and vessels geometry opposes flows, heart rate independent, these are these factors. And the heart rate dependent factor is called inertia, that is, it opposes the rate of changes of the flow. It depends upon dynamicity of the blood flow. That hemodynamicity differs, and that then heart rate differs. Another is will get heart rate dependent, that is distensibility, that changes of blood volume, opposes the blood volume. Why? What is the importance of it, of the pulse? That is also called it is a mirror of heart. You can see, you can evaluate heart by measuring the pulse. You can see the arterial wall, conditions of arterial wall, how much it is propagating, what is the power of recoiling. When the distension is happening, after that when it is going to contract, that is called recoiling. Whether this recoiling is there normal or not, that we can feel. We can estimate systolic blood pressure and state of heart in circulations, what is the condition of the heart in circulations, and we can detect the arrhythmia, some arrhythmic problems are there or not. If you study the heart, you will see a lot of rhythmic problems are there. Some regular rhythms, irregular rhythms. Actual normal character of the rhythm is regularly irregular. It might be regularly irregular or irregularly irregular. A lot of some clinical conditions are there where we will get it. Some diagnosis of atrial regurgitations and acute left ventricular failure, that could be done by measuring the pulse. These are the common locations of pulse. You will get where commonly we can find see the pulse. We have to examine the pulse. Lot of cases, lot of patients will be there where you cannot get the radial pulse, might be absent. Some other causes, some anatomical abnormalities might be there, or some other diseases are there where you are not getting this radial pulse. The complete heart block patient, suppose heart failure patient, you may not get the radial pulse, but you have to check the carotid pulse, or you have to check the brachial pulse. So that is how we should know what are the places other than brachial or other than radial pulse which is commonly examined. There are radial, brachials, carotids, femorals, popliteals, temporal, facial, maxillary, and peripheral legs also, the dorsal spadish and posterior tibial artery. These are the places where we can feel. Actually, what happens? The superficial arteries, what heart is exerting pressure, this force is propagated through the artery all over the body, but we can feel it in superficial arteries, what is palpable, and that palpable artery we can feel the pulsations. Suppose in case of radial artery pulsation, where we will get, that is at the wrist joint, we have to check the radial pulse, and superficial temporal artery or the superficial temporal artery at just in front of the ear. Just this is a tragus, just in front of the tragus you can feel this superficial temporal artery pulsation. External carotid artery pulsation at the neck, just in the lower 1/3 of the sternocleidomastoid muscles is medial to it, a deep palpation is required. Over the cricoid cartilage, there you can feel these carotid pulsations. And the subclavian artery, that is just at the lower sternal end of the clavicle, lateral to the sternocleidomastoid, on deep palpation you will get this subclavian pulse. Or this is anatomically present over the subclavian triangle, this posterior triangle of the neck. It is very, very important, this posterior triangle. Among these subclavian triangle is there, which is where you will find this subclavian artery, normal course of subclavian artery, and on that region the sternal end or inner end of the first rib and sternal end of the clavicle, if you feel, then you will get subclavian artery pulsations. Maxillary, the retrograde in front of and slightly below the ear it is found, and here just below the ear, just at the level of this where we are feeling temporal pulsations. Below that, against the maxilla, if you feel and a deep palpation, you can feel this maxillary artery pulsations, like brachial artery, facial artery, told you over the face, over the jaw, over the sternal angle. If you see this mandibular angle, this mandibular angle in 1 inch in front of the mandibular angle, if you feel, this is the place of facial artery pulsation. Femoral artery pulsation, that is a mid-groin region. If you have to draw a line from anterior spine to the symphysis pubis and mid-line of it, this is the normal course of inguinal ligament. At the midpoint, nearest to the midpoint, just below it, you can feel the femoral artery pulsations. Popliteal artery, it is on the popliteal fossa, just at the back of the knee joint. You have to feel this popliteal artery pulsation. Dorsal spadish, just below the ankle or on the dorsum of the foot, and particularly if you see the foot, the tendons of the foot, there will get external hallucis longus tendon, and in between external hallucis longus tendon, just lateral to the external hallucis longus tendon, and medial to extensor digitorum. On this, in between, you can feel this dorsal spadish artery pulsations. What are the factors which influencing the pulse? That is a stroke volume, rate of ejection, distensibility of the peripheral arteries, and peripheral resistance. What is to felt, what is to come across this force exerted in the heart, and pulse rate, pulse pressures, size of the vessels, distance from the heart. So that is how these are the factors which is influencing this pulse. How to feel the pulse? The radial pulse, some cardinal rules are there to feel the pulse. We have to use middle three fingers for to measure this radial pulse. We have to put this is one is a proximal finger, proximal to the heart. This is called index finger. The middle finger, it is at the middle, you have to feel, and the ring finger, which is distal to the heart. It has different purpose to feel the pulse. Suppose this proximal finger, which is stopping the circulation initially, just before when we are trying to check the pulse, we have to stop the circulations. It is stopping the circulations with the index finger. Middle finger is taking its volume and frequency and rhythm, everything is checked by this middle finger. And ring finger, it is for this. Sometimes what happens, ulnar artery pulsation might be propagated to that part. So for this, we can stop this ulnar artery pulsation propagation. We have to use this ring finger. As we know that radial artery is connected with the ulnar artery in terms of deep pomerage. That is how we have to. This finger is choking the sounds, which can be carried to the radial artery. So radial artery pulsation we have to check like this. At first, this artery is completely occluded with this proximal finger, and then gradually release the patient until maximum feeling of the pulse wave is perceived by the middle finger. In case of carotid artery pulsation, the patient lies down on the bed, and bed should be elevated 30 degrees, and carotid pulsation may be visible just medial to the sternocleidomastoid, which I told this in carotid triangle along the course of the carotid artery, and we have to give a pressure over the cricoid cartilage. Just this is a thyroid cartilage, just below this you will get a cricoid cartilage, and against the cricoid cartilage if we give a pressure on the just medial to the sternocleidomastoid, press posteriorly, and we can get carotid artery pulsation. But one thing we have to keep in our mind, that both the sides carotid artery should not be palpated, or should not give pressure on both sides carotid artery. It may hamper the circulation to the brain. Brachial artery, the patient's arm should be at the rest. It should be elbow should be extended, and you have to use the thumb of the opposite hand. Which brachial artery we are pulsating, we are going to measure. Suppose a left brachial artery, if we want to palpate, then you have to use right hand, and right brachial artery we have to use the left hand. And other fingers, it should place it just medial to the. You have to put this thumb just medial to the biceps tendon, just medial to the biceps tendon on this cubital fossa. That we will get this brachial artery pulsations. Femoral artery pulsation, I told you, just midway between anticipatory spine and symphysis pubis. Popliteal artery, also popliteal fossa. And for the popliteal artery, we have to use both these four fingers. These four fingers, it should be placed posterior to the knee joint, posterior surface of the popliteal fossa, and the two thumb, both the thumb, we have to give a pressure over the patella, so that we can get a midline by these four finger of each hand. It should be along the midline of the popliteal fossa, and another two finger of both the hands, it is giving a pressure to the tip over the patella, and we can easily palpate the popliteal artery pulsation. Dorsalis pedis, that I told you, this is how we can palpate. That is, you have to look at these two muscles tendon. One is flexor hallucis longus, another is flexor digitorum. In between that, you have to palpate. You have to find out just below the ankle joint at the dorsal surface of the foot. You will get this pulsation, dorsalis pedis pulsation. Posterior tibial pulsation, just you place your finger behind and slightly below the medial malleolus and of the ankle joint, there you can feel. So, what comment we have to put, what report you will get, what is the thing we will note that is to be reported in the pulse, that is rate, rhythm, volume, force, tension, and comparison of to both the sides, and special characters any felt during checking of the pulse, and conditions of the atrial valve, it should be reported. If you see the rate, the normal rate is 60 to 90 beat per minute. Above 100, when this beat reaches above the 100, then we can tell the patient is suffering from tachycardia, and if it is below 60, then it is bradycardia. And for that, when normally we are checking the pulse, if the pulse no abnormality is found on normal examination, then we have not to wait for 1 minute. We have not to calculate. We can calculate rate by counting up to 15 seconds only. But if you find any abnormality in the rhythm, in volume, then we have to check it for 1 minute. 1 minute, and you have to compare it on both the sides. So, irregularity, if you find, then you have to go for both the sides. You have to check. If there is any deficiencies, pulses deficits, then you have to go for. Some rhythms, we have to check. On rhythm report, what we have to check? Normal characteristics of the rhythm is regularly regular. But in case of some alterations, some abnormalities are, that is regularly irregular. Regularly irregular, what does it mean? That means one beat is omitting after 2 beats. After every 2 beats, 1 beat is low or 1 beat is missed. That is called regularly irregular. And irregularly regular, suppose after 2 beats, 3rd beat is stopped. Another 3 beat is normal, next beat is stopped or of low volume. Then we are telling it is an irregularly regular. So what are the clinical conditions where you can get it? Very regularly irregular, that is very commonly found in fixed atrioventricular AV block, AV nodal block, or paroxysmal atrial tachycardia. On that cases you will get paroxysmal atrial tachycardia is a condition where both things may happen, or regularly irregular or irregularly irregular. Atrial flutter, regularly irregular things happening, and atrial fibrillations you will be getting irregularly irregular. Atrial fibrillation, what is this condition? Atrial fibrillation means the heart muscles is twitching. Instead of contraction, the left ventricular muscles are twitching. Incomplete contraction of the left ventricular muscles. That is the condition that is known as atrial fibrillations. On atrial fibrillation, it is happening. In case of volume, you will get hypovolemic and hypervolemic. In case of hypovolemic, you will get high pulse pressures, and systemic volume is very high. Systemic volume is very high in hypervolemic circulations, and also during anxiety, we have seen that during anxiety our pulse rate is going to be increased. It is increased from the normal pulse rate, is going to increase, and systolic volume is going to be increased, and exercise is also conditions, chronic heart block, and aortic regurgitation. In fever, very common finding. In fever, we have seen the tachycardia. We can measure the temperature also by measuring pulse. Suppose every 10 beat of pulse means 1 degree Fahrenheit temperature is raised. 1 degree Fahrenheit temperature is raised. Suppose 70 to 80 is a normal pulse rate. On these conditions, if it is 90, then that means 98 is the normal temperature, 98 degree, then 99 is the body temperature. By that way, we can calculate body temperature also by counting the pulse. So, in case of fever, this rate is increased. In anemia, hyperkinetic circulation is happening. In case of anemia, why anemia is happening? In anemia, this tissue anoxia is happening. In case of anemia, due to poor level of hemoglobin poor level of hemoglobin, proper oxygenation is not happening. The oxygenation is very less. A deficient oxygenation is causing peripheral demand of oxygen, and circulation is going to be hyperkinetic. Thyrotoxicosis, in thyrotoxicosis, BMR is raised, and in that case also oxygen demand is raised, peripheral demand of oxygen is raised, and this condition is causing hyperdynamic circulations. Actiovenous fistula, sometimes actiovenous fistula, this is a common patent ductus arteriosus conditions. In these cases also hyperdynamic circulation is happening, very is a disease and systemic disease that is also causing these hyperkinetic circulations. Hypovolemic or hypodynamic circulations you will get very commonly found in hypovolemia, and hypovolemia leads to shock. In case of shock also it is very common. Chronic congestive heart failure, where the right heart is congested with the blood and proper amount of blood in the left heart is not there. That is how this hypovolemic volemia is there, and in contraction stroke volume is going to be reduced. That is how hypovolemic circulations we are getting. Stenotic valvular disease, the same thing is happening. If the mitral stenosis is there, or aortic or tricuspid stenosis is there, in every case there is less amount of blood available in the right or left ventricle. Therefore, that is how the volume of the blood is going very less, and it is happening. Myocarditis or constricting cardiomyopathies, on every cases their contraction is less. Myocarditis, in these conditions also contraction is less. So again peripheral demand increase and circulation is hyperkinetic. Cardiomyopathy, on every case of dilated cardiomyopathy as well as constrictive cardiomyopathy. On both the cases, dilated cardiomyopathy means their myocardium is going to be affected. Elongated myocardium is not sufficient enough to give a proper stroke, to maintain a proper stroke volume. It is not maintaining stroke. Ejection fraction is very less. Ejection fraction is very less. That is how hypovolemic circulations is coming up. The pulse volume is going to be very less. Another things we have to check, that is a force. It indicates the systolic blood pressures. And high force you will get atrial regurgitation, patent ductus arteriosus, hyperdynamic states. Low you will get low force in shock, cardiac failure, stenotic valvular lesions, cardiac tamponade in this case. What is cardiac tamponade? Cardiac tamponade means pericardial effusions, and that is also a kind, it is producing a constrictive cardiomyopathy. Tension, it indicates systolic blood pressure. We have to compare both the sides of any pulsation. When we are going to check, we have to check of both the sides. Suppose radial pulse of both hands, carotid artery of both the carotid pulse of both the hand. Both sides we have to check, as because one side there might be compressions, that is how some abnormality is coming up. Some atheromatous plaque, it may cause some abnormalities, filling of pulsation of any sides. Some embolus is going to block, that is how proper circulation is happening, and you may not get pulsation in a single side, and you cannot judge a case with a single side. If you check both the sides, it can give lot of other information for its differential diagnosis. It will help. This is a normal curvature of the pulse. You will get two phases. One is systolic phase and there is a diastolic phase. You will get this is a sharp raise. After that, on systolic phase, this is a rounded. It's not the apical you are getting, not a peak you are getting. It is a little rounded. After it is coming down. This is up to systolic phase, and this phase, this notch, it is known as dichotic notch. This dichotic notch is denoting atrioventricular valve closure, AV valve closure, and after that this is a diastolic phase starts and it is coming out. And before this atrioventricular valve closure is showing a notch, this notch known as dichotic notch. So normal pulse, you will get the central aortic pulse wave is characterized by the fairly rapid raise of somewhat rounded peak, and anagogic shoulder you will get, and dichotic notch you are getting on this diastolic phase. So this is the normal pulse. This is a normal pulse of different pulses. If the aortic pulse, you will get this type of picture. This slope is variation, variations of slopes are there. This variation depends on the location of the arteries, and this variation depends on the distance from the heart artery and heart locations. That is, you will find some anagogic pulse or pulse of status is known as, status means lazy conditions. Tab, the word came from tab, a lazy condition, lazy in character. That is slow rise. This is not a sharp rise of the what we have seen in a normal character of the pulse. It is sharply raising. It is not, we will get here. There are slowly raising and slow falling of this curve, and duration of pulse is very prolonged, amplitude is very small, very lazy and lazy character of pulse you will get, and it is very commonly found in aortic stenosis cases. Dichotic pulse, one peak in systole and one in diastole. Two peaks are coming up. Here two peaks are there. That is called dichotic pulse. It is very, very common in dilatory cardiomyopathy patient, in left ventricular failure patient, and cardiac tamponade dehydrations. In these cases, dichotic pulse are very, very common. Some other abnormalities is very, very common in pulses. Some other abnormalities which we can find in some obstructive arterial disease, peripheral obstructive arterial disorders. On these cases, we may find some abnormality of the pulses, some dissecting aneurysm or dissecting aorta, aortic aneurysm, Takasaurus arteritis, which is known as pulseless disease. We may not get this pulse. Somewhere some left ventricular outlet tract obstruction, if there is an obstruction on the aorta. Suppose in case of coarctations of the aorta, it is happening very commonly, outlet obstruction is happening. On that cases also we will find some abnormalities, some abnormal pulses we can find. What are these? Pulses perverse. You can easily compare with the normal pulse curve and this pulse curve. You will see this raising is going to be very diminished. The pulse, the pressure is very diminished. Pulse will very weak, very small, which is very, very common in case of heart failure. What is reflecting from this curve, we can easily detect that stroke volume is going to be very less. In case of restrictive cardiomyopathy, there also stroke volume is going to less, and that is how this slow pulse rate, we are getting slow pulse where metastenosis, increased peripheral resistance, and this is pulsus perversus, that also TADUS will say both cases, both things will find in aortic stenosis cases. Aortic valve stenosed, and stenosis aortic valve means incomplete opening also. As it is deficiency in closing and incomplete opening also. Incomplete opening means less amount of blood is going to be ejected from the left ventricle to the aorta. That is how pulsus perversus we can find. Bispharetic pulse, instead of atrial pulse with a double systolic peak, a second peak we are getting. You can see here, a second peak is coming up. Here one peak was there, but second peak is coming up. This is the dichotic notch, and before that another peak has come up. This is represent a reflected wave from the periphery, and it may provoke rapid LV ejection, left ventricular ejection during early systole, and rapid decline due to left ventricular outlet tract obstruction. Bigeminal pulse, there is a normal beat alternating with a premature contraction. A contraction is coming up, which is very premature. This premature contraction is coming up, and that is known as bigeminal pulse. This premature beat is is due to the stroke volume decrease. The diminished stroke volume is happening. How much stroke volume is there? Here it is comparatively very less. So this graph is showing you that this low systolic stroke volume, and it is decreased. This is what are the causes? Decreased BP. Very common is hypovolemic shock, and same in cardiac tamponade also, and some increased peripheral resistance. Suppose in case of fever, it is very common. Pulsus alternans. This is a variation. Alternans means alternate pulse is of low volume. You see, this is a normal volume pulse and this is low volume pulse. Pulsus alternans, it doesn't mean that one beat is going to be absent. It is an immeasurable beat. You cannot calculate this beat. This beat is going to be as if it is absent. A low volume beat. Low volume beat means low cardiac output. Insignificantly low cardiac output it is there. And this causes is left ventricular failure, and patient with a severe aortic regurgitations and frequent precipitated ectopic beats is coming up. Ectopic beat. What is ectopic beat? Ectopic beat is a beat which should not come in between. In between two beats, another unwanted beats has come up. That is known as ectopic beat. So this is a like unwanted beat. On the previous slide which I have checked, that like they say unwanted that beat is coming up. So this is the normal rhythm, but here another beat has come out. Pulsus paradoxus. Pulse pressure when drops down below 20 millimeter of Ig. What is pulse pressure? Pulse pressure means the systolic pressure minus diastolic pressure. That is telling you the pulse pressure. So that is by sphygmomanometer we can check. Also pulse meter can be measurable. You can measure if you are very experienced on measuring pulse. On palpation also we can see the pulsation. We can measure this pulsation. Normally systolic at palpation of 8 to 12 meter Ig during inspirations, but it should be evaluated by the sphygmomanometer. On systolic pressure and diastolic pressure we can check, and after that we will get pulsus paradoxus. And what are the causes? The cardiac tamponade, COPD, and hypervolemic shock. Hypovolemic shock, not hypervolemic, it's a hypovolemic shock, infrequently constrictive pericarditis or restrictive cardiomyopathy. It is very common. Bounding pulse, it is also known as water hammer pulse, or also Corrigan pulse. This is known also Corrigan pulse. It is very commonly found. Commonly you will find hypoxicosis in anemia, extreme bradycardia. In these cases, you will find this bounding pulse. So that's all about the bounding pulse also. This is one kind of abnormal pulsation. So this is the end of the class. If you have any questions, you can send me by mail. I'll give you response. And in turn, my email ID also I'll provide you with the link of this slide.